Hello, everyone. Can you hear me? My name is Stephen Itzkowitz. I'm a gastroenterologist at Mount Sinai Hospital in New York City. My entire career has been spent studying colorectal cancer, and my efforts in the last 20 years have centered around identifying and undoing racial and ethnic disparities in colorectal cancer screening. And for the last 10 years, I've done a considerable amount of self-education and training to help me function better as an anti-racist. The NCCRT steering committee felt that it was crucial at this year's annual meeting to have a frank conversation about the impact of racism on healthcare and CRC screening. Can I have the next slide, please? As we heard from Rich Wender, a core value of the 80% in every community campaign is to emphasize health equity among priority populations. Next slide. I wish to bring to your attention the many tools and guidebooks that the Roundtable has developed in recent years that address the needs and interests of specific patient populations. Please visit the NCCRT website for these helpful resources and more. Next slide. And I'm pleased to announce that the Roundtable has attracted funding from Quest Diagnostics for a new market research initiative that Dave Greenwald also commented on. This work will enable us to develop tested messages for reaching unscreened populations, particularly Black Americans. Next slide. For this session, in order to maintain focus in the short time that we have, we'd like to frame the conversation of colorectal cancer screening inequities around African Americans. We're well aware that health inequities clearly affect Indigenous, Latinx, Asian, and many other communities. But racism in the United States was founded on the condemnation of Blackness. And unless we begin to understand the impact of racism on the Black community, we cannot fully appreciate the foundation of healthcare inequities in other communities. We are aware that having a conversation about racism often makes people uncomfortable, especially among a large mixed race group audience. In my own weekly neighborhood anti-racism group meetings, we follow a few ground rules which I'd like to propose that we follow here. First, please consider this a safe space to share your ideas and feelings in an authentic way. Secondly, we should be non-judgmental and as we listen to our colleagues. And third, if you feel uncomfortable, you've reached your growing edge. And instead of retreating from that place, lean into it and consider why you feel that way, because it's often a teachable moment. Racism is baked into every system of US society, from housing, education, and jobs, to criminal justice, transportation, media, and healthcare. It is so ubiquitous as to be invisible, because it has been such a part of American society for over 400 years. And like smog, everyone breathes it without realizing that it harms us all. Racism dehumanizes everyone, regardless of race or ethnicity. When it comes to racial barriers regarding colon cancer screening, we can consider racism at 4 levels: the patient, the provider, the healthcare system, and health policy. I'm sure we will touch on all of these levels as we have our discussion today. It is now my pleasure to introduce our esteemed speakers for this session. Dr. Rhea Boyd is a pediatrician and child advocate, Director of Equity and Justice for the California Children's Trust. Dr. Marcella Nunez-Smith is Associate Professor of Internal Medicine, Public Health and Management at the Yale School of Medicine. And Dr. Darrell Gray is Assistant Professor of Medicine and a gastroenterologist at the Ohio State University Comprehensive Cancer Center. Before we have each of them speak, we would like to share the following PSA with you.
An important message from your gastroenterologists across America. Colorectal cancer is the second most common cancer killer in America.
The death of Chadwick Boseman at the age of 43 to colorectal cancer fills us all with so much sorrow.
It reminds us that colorectal cancer happens in young people.
And that Black men and women have the highest rates of getting the disease and dying from it.
But we can stop colorectal cancer in its tracks.
The disease is preventable, treatable, and beatable when it gets screened at the right age.
For most, screening starts at age 50.
But for high-risk groups like Black men and women, screening starts at age 45.
If you have a family history of colorectal cancer or other medical risk factors for the disease, screening should start at age 40 or even earlier.
Chadwick Boseman's untimely death is a wake-up call for all of us.
We as Black gastroenterologists and colorectal cancer warriors are fighting to make colorectal cancer screening and prevention a priority.
When caught at an early stage, the survival from colorectal cancer is 90%. But when caught at late stage, the survival is only 11%.
And this is why prevention and paying attention to any symptoms you may have is so important.
Talk to your doctor today about colorectal cancer screening. It can save your life.
Visit cancer.org and gi.org for more information.
Thank you, Caleb. So the way we'll run this session is each of our speakers will say a few words for approximately 8 or 10 minutes each. And then we want to leave a lot of time for conversation and discussion. But while they're speaking, please feel free to ask questions in the chat function. And when we get a chance, after all the speakers have spoken, we'll address the questions as they come in. So it's my pleasure and honor now to introduce our first speaker, Dr. Rhea Boyd.
Hi, y'all. Thank you so much for having me today. I'm just going to share my screen. Hold on one sec. Okay. Thank you again so much for having me to be a part of this critical conversation. As Dr. Itzkowitz said, I am a pediatrician, a public health advocate, and a scholar who writes and teaches about the relationship between racism and health. And so I'm going to kick off our conversation by describing that greater context to us as a group. What is that relationship between racism and health? Here, I think it's critical to turn to the words of journalist and author Ta-Nehisi Coates, who in his book, Between the World and Me, laid it out so clearly. As he said, but all of our phrasing, race relations, racial chasm, racial justice, racial profiling, white privilege, even white supremacy, serves to obscure that racism is a visceral experience, that it dislodges brains, blocks airways, rips muscle, extracts organs, cracks bones, breaks teeth. We must never look away from this. We must always remember that the sociology, the history, the economics, the graphs, the charts, the regressions all land with great violence upon the body. In short, racism kills folks, and that's why we're going to talk about it today. Sometimes when we imagine who prematurely suffers death at the hands of racism, we think strictly about adults. But as a pediatrician, I have to share that racism also kills babies. This is a 2020 study that was published in the Proceeding of the National Academies of Sciences that looked at 1.8 million hospital births in Florida over almost a 10-year span. And what they found is that when Black newborns had a Black physician, they were able to narrow the Black-white infant mortality gap by half. Most notably, the researchers found that that narrowing, that association was most strongly actually when babies were the sickest and in hospitals that cared for predominantly Black babies. This data makes us have to ask questions about how segregation and divestment in communities of color shape the outcomes for Black babies. Racism also kills healthy children. Again, this is a study just from a few months ago this year that looked at 180,000 apparently healthy children in the 30 days after having a surgery. What they found is that Black children, when compared to white children, had over 3 times the odds of dying. Again, these are healthy kids, had over 3 times the odds of dying within 30 days of a surgery, and a greater relative odds of having post-op complications and adverse events. This database anonymized the hospitals, so we couldn't say whether segregation was a major driver of this health inequity. But it begs important questions about the quality of care that even Black children receive in hospitals across the nation. And obviously, as we've seen through the pandemic, racism kills adults. This is data from APM Research Lab that looks over time at the racial health inequities that have emerged during the current COVID pandemic. And the first thing we see is that first, those inequities are widening. As you go from April, when they first started to be reported, to just a few days ago, what we see is that the gaps between racial groups and their COVID mortality is extending. The sharpest or steepest rise in COVID mortality is for Indigenous populations right now, but the population that remains having the highest COVID mortality rate is Black folks in this country. So what we have to acknowledge is that racism is a devastating root of chronic, undertreated disease and completely premature death in this country. And so to adequately respond at scale to racism as the public health crisis that it truly is, we in medicine have to name racism as a cause of racial health inequities. We have to identify the mechanism by which racism drives racial health inequities, and then we have to work to eliminate racism. When it comes to naming racism, we are not doing a good job. This is a 2018 systematic review that looked at the 50 highest impact journals between 2002 and 2015. And over that span, only found 25 articles that actually named institutionalized racism in its abstract. And when they looked closer, what they found is that institutionalized racism was really only a core concept in the article in 16 of those 25 articles. Since the beginning of this pandemic, much more research and attention has been focused on racism as a driver of racial health inequities that we've seen emerging from COVID-19. But historically, we have failed to adequately name racism as a cause of racial health inequities. We then, after we name racism, always have to identify how it works. It's insufficient to just say racism caused that. You then have to say, how did racism cause that? We know that racism harms health because of legacies and current practices right now of racial exclusion, like segregation, racial discrimination, like bias or prejudice, disinvestment in communities of color, and violence in communities of color, whether that violence is the physical violence of policing or the structural violence of inaccessible healthcare. Together, these factors concentrate disadvantage in communities of color, create adversity for children of color that follows them across their life course, and shapes population-level opportunities to be well and provides the perfect conditions for folks of color to be sick. If we don't identify the mechanism by which racism works, we as researchers and as clinical practitioners exacerbate patient blame. And I want to focus here for a second, because a common and accepted manifestation of patient blame right now is this undue focus that we as a field have on patient mistrust as a potential driver of racial health inequities. You hear this all the time. Part of what drives the fact that there's gaps in racial groups for certain health outcomes is because certain racial populations mistrust the medical system. That's a form of patient blame that we need to identify. As colleagues and I wrote in Health Affairs blog earlier this year, while patient trust obviously shapes healthcare use behaviors and is of course important to patient-physician relationships, and I put this in red and bolded it just so that we all carry this home with us, the fact that we have persistent racial health inequities across nearly every major health index reveals less about what patients have failed to feel, trust, and more about what our systems have failed to do, eliminate racism. To be clear, patient trust will never solve racial health inequities. I'm going to say that again. Patient trust will never solve racial health inequities or narrow gaps in outcomes. Eliminating racism does. And eliminating racism can then build patient trust. But the direction of that relationship is critical, and it begins with eliminating racism. And so how do we do that? To effectively eliminate racism, we as a field actually have to start moving towards and contending with abolition. So how do we abolish racism? One way that Dr. Itzkowitz already described is to advance anti-racism. To use the words of scholar and abolitionist Angela Davis, in a racist society like the United States is, it's not enough to be non-racist. We have to be anti-racist, because often how institutionalized racism shows up is inaction in the face of need. It's standing by while we allow our systems to perpetuate harms systematically for certain racial and ethnic groups. It's when we focus on mistrust instead of focusing on what our systems need to do to garner trust and keep folks safe. So anti-racism will require more than all of us than simply being passive as our healthcare system harms certain racial groups more than others. Abolition of racism requires that we start to erect sanctuaries within our healthcare system. Why do I say that? I say that because earlier this year, Harvard historian Leah Wright-Rigueur shared some words that have moved me and changed the way that I pursue my work. What she said is that Black people live without sanctuary in this country. And colleagues and I in the New England Journal added the fact that Black folks live without sanctuary from the intersecting, compounding, overlapping forms of racist violence that threaten and shorten our lives, right? Black people aren't safe from the racist violence of having police called on you when you're on a city block. Black people aren't safe in their own homes when they're just trying to go to sleep at night, like Breonna Taylor, from the racist violence of policing. Black folks aren't safe in our healthcare institutions from the racist violence of inaccessible healthcare. There are few sanctuaries that Black folks particularly have in this country from racism and its violent harms. And so we also have to start to conceptualize our interventions as building sanctuary, as ensuring that when patients seek care from us and our institutions, they are not subject to the violence of racism. And we have to confront how white supremacy harms the health of our entire population. Here, I want to turn to the words of the Kerner Commission. The Kerner Commission was a commission that was put together by President Lyndon B. Johnson in 1967, following the long, hot summer of 1967. The long, hot summer of 1967 is referred to that way by historians because during that summer, there were 159 race massacres across the United States, all sparked by an event of police violence against a Black taxi driver in Newark, New Jersey. After that summer of uprisings, the president put together a commission to say, why did that happen? What's going on in this country? And following the summer of uprisings we've had, I think it's important to return to these truths. What the commission said is that our nation is moving towards two societies, one Black, one white, separate and unequal. But this deepening racial division is not inevitable. This movement apart can be reversed. Choice is still possible. But I put an asterisk by the end of their conclusion because I think it's really critical. What this commission that was nearly completely white males said is that what white Americans have never fully understood, but what Black Americans can never forget, is that white society is deeply implicated in the material conditions that impoverish and harm the health of Black folks. White institutions created those material conditions. White institutions maintain those material conditions. And white society then condones the health inequities that exist on the other side. And so we also have to talk about what it means to confront white supremacy such that we can advance anti-racism in healthcare. In conclusion, we have to abolish racism from every institution, every practice, every policy, and every social norm in which it operates and often hides. The future health and well-being of our kids and our kids' kids will absolutely be measured by how well we succeed in this. So thank you again for having me. I'm excited for this conversation. Here, I'm going to pass it off to Dr. Marcella Nunez-Smith from Yale School of Medicine.
Thank you so much, Rhea. I'm sure I join with everyone in the audience for saying that is the perfect grounding for our conversation today, and really appreciate all of your thought leadership in the space. So as Rhea said, I'm Marcella Nunez-Smith. I'm Associate Dean for Health Equity Research at Yale, where I'm also Associate Director for Community Outreach and Engagement for the Yale Cancer Center. It's a great privilege to be with all of you today, to be part of this esteemed panel. With the few minutes I have with you, I'm hoping to just kind of hit on a few key topic areas that I think are relevant, and hopefully we'll be building upon what we've just heard. A lot of the work that I do in my research center speaks to these topics in particular. So I want to consider with you healthcare discrimination. We've just heard about societal discrimination and racism and how that affects health. And for us, I'm a practicing primary care internist, a good opportunity to consider what happens within our healthcare system. And then I want to talk about workforce diversity. I think that also is one very important piece of this puzzle that we're all grappling with as we work towards achieving anti-racist healthcare systems, but also health equity for our patients and our communities. And then I just want to think for a little bit as a PCP about kind of the role that we can play as good partners in this battle against colorectal cancer. So I'll get started with healthcare discrimination. And we know that racism is endemic across US institutions. That's what we just heard so eloquently. So there's no reason for us to think that healthcare settings would be any exception. And in fact, they're not. We see across every condition, every specialty, every domain, differences in outcomes for our patients, and really differences in the way that we manage the care of our patients and the way that we refer them, and differences in quality of care. So we know that this long history of medical violence and really ongoing experiences of healthcare discrimination contributes to communities of color not being anxious to come seek care, not being excited and enthusiastic to participate, for example, in clinical research and clinical trials. You know, early on in the COVID-19 pandemic, back in May, in my research center, we had a chance to partner with the NAACP as well as with the African American Research Council to conduct a national poll of African Americans. And over 600 people responded, and we asked about sort of anticipatory bias and discrimination, right? We said, do you think that Blacks in this country are going to be tested at the same rates as whites? What about getting admitted to the hospital for COVID-19 or access to new therapies and treatments? And we even asked, do you think that Blacks are as likely as whites to have everything done to save their lives once admitted and in critical care in the hospital? And the overwhelming majority of respondents to that poll, over 60%, all were worried and concerned and knew that they would experience a bias in the healthcare system across all of those different questions and parameters. And when we first came out with that in May, we got a lot of pushback and skepticism on those findings, and yet there is evidence of that bearing out. So to really echo the point that people, I think, made very rational choices, particularly Black and Brown people, to be skeptical of healthcare. And it is on us to think about how racism and discrimination really drives the reduced quality of care we often see in these populations. We know, for example, in colorectal cancer, African Americans are less likely to receive newer chemotherapeutics, for example. We also know that there is great variation in care, and African American patients are less likely to be treated in high volume facilities where we know that tracks with better outcomes. So some of the things that we need to do, I'm a data person, so I often lead with that conversation. One of the greatest violences we commit as a healthcare system is the invisibility of people in the data. And, we're talking about African Americans today, but people will understand intersectionality. And so we know very little about who we're taking care of and the lived experiences that they bring. So it's important that we collect really high quality, both self-identified data, but also data about these lived social realities, often referred to as social determinants. But we need to first be consistent and systematic in documenting inequities, particularly when we see them in things like screening and treatment. And eventually think about linking those inequities with high impact consequences. Consider, public reporting, that degree of transparency and accountability by linkage to payments and penalties and reward systems. Also, in my research team, we very much center on the patient voice. And we see the need for a patient-reported measurement approach that really captures the experience of discrimination. We have developed a measure called PREDICT, or the patient-reported experiences of discrimination in care tool, that really brings the perspectives of disparity populations into this quality of care metric space and offers a way forward for health systems who want to standardize the measurement of discrimination, respond to it, to be able to do so. And so I think it is encouraging that so many healthcare organizations now are speaking of the need to develop and institute and practice anti-racism throughout all policies and practices. And certainly I look to data as one of the points to begin that, but also for us to think about a diverse and inclusive healthcare workforce. So when we consider this question of workforce diversity, we know specific racial ethnic groups are grossly underrepresented across the physician workforce. Roughly African Americans make up 13% of the US population, but only 5% of the physician workforce. And if you consider the proportionality question, we see that on that macro level. But really when we get into healthcare systems, particularly academic health centers that are largely serving and abutting communities of color, I would argue the representation should even be greater and should mirror that of the surrounding communities and the catchment area. We know that in the physician workforce, representation declines along the career path. I am faculty at an academic health center, and the reality is reflected across the country where the most senior levels of leadership, we see very limited representation. African Americans are 2% of professors in the United States. And we see this dramatic drop off from assistant professor along the pipeline. I'm often asked, why do we see such, this difference? Why are there fewer African Americans, in particular in the physician workforce? This wasn't always the case. And, as I age, I seek to become a better student of history. I think many of our answers can be found there. We have to grapple with the history of racism and discrimination that existed in professional medical organizations that actually led to the denial. We had robust pipelines. We had many schools of medicine that produced outstanding and illustrious physicians of African descent. And the Flexner report sort of came out and called for the closing, really the majority of those historically African-American medical schools. And so between sort of this systematic closure of the schools that were there to provide education to people of African descent, and then the racism and discrimination in professional medical organizations that really limited access to licensure and practice, perhaps it's not too hard to understand how we went from really having communities that were often cared for by physicians who were from those communities and of those communities to where we are now. So a lot of our work has shed light on the fact that we have a bit to do in our own house around equal access to things like honors and awards and professional associations, and where people can really feel valued and respected at work. So I think I just want to say one or two things very quickly, because I do want us to have time for discussion around the primary care provider, where we also see the need for increased representation and diversity and inclusion. But as a primary care provider, I want to just remind everyone that we are here to help with the co-management, the transitioning of patients who have a diagnosis of colorectal cancer. We are here to promote screening. We are partners in this work, and we know that those 1 to 2 years post-treatment especially is a time where we should really be partnering together as PCPs and oncologists and just thinking more intentionally about transition and survivorship. So I think in conclusion, I just want to leave you with 3 thoughts. So, healthcare systems, we certainly attest and aspire to alleviate suffering, but the current framework through which we operate and our system of incentives and rewards often upholds and reproduces racism and discrimination. As we think about anti-racism and anti-racist healthcare systems, we have to center on the patient voice. We must be sure that we are collecting and responding to data as we try to achieve equity and justice. So while work is being done to address racism in the medical profession and in medical school admissions and throughout, we need to be persistent and tireless in dismantling roadblocks where they exist to equitable inclusion. We have to be innovative, and we need to fail quickly and pivot when our approaches towards social justice are not working. And lastly, this is a critical conversation today. Too many of our neighbors, friends, brothers, and sisters are being lost to colorectal cancer prematurely. So we have to do more on the cascade, from screening to treatment to follow-up, to ensure equity in access, equity in quality. And as PCPs, we have important partnership roles to play. So with that, I'll pause and turn it over to my colleague, Dr. Darrell Gray.
Thank you so much for that. And thank you to the NCCRT, to Drs. Winder and Smith, and certainly to Steve for moderating this session. It's truly an honor. I know I look straight-faced, but I have to say I am extremely excited to be on a panel with Rhea and Marcella. I could hardly sleep last night, so I'm extremely proud to also be part of the 2% that Marcella mentioned. I'm an associate professor at The Ohio State University Wexner Medical Center, and so am part of that 2% that she mentioned of African-American physician clinicians working in academia. I want to specifically talk about the intersection of racism and colorectal cancer screening. And certainly, as Marcella was just suggesting, it's not just restricted. As we think about colorectal cancer throughout this conference, NCCRT, know that it extends beyond just the screening completion and extends to survivorship, diagnosis, treatment, et cetera, as well. But I'm going to share a slide because I want to put a visual to some of the things that I'm going to be sharing with you today. So certainly amidst this time, this pandemic, COVID-19 has really taken a magnifying glass to some of the already pre-existing disparities that have been around for hundreds of years. And this now allows us to really examine ways in which we as a society can continue to improve on some of the harms that have been done, as Rhea mentioned earlier in her talk. But as people were, in February and March, starting to think about COVID-19 and the populations that were disproportionately burdened by it, one of the things that became glaringly clear, and many of us who were in this work were not surprised, were that people of color, Indigenous and Black people of color, particularly African Americans, were disproportionately burdened by COVID-19. Similarly, as we look at colorectal cancer, the same is happening with the highest incidence and death rates amongst African Americans. You saw a PSA at the beginning of this in which we were giving kind of tribute to Chadwick Boseman, who died in his 40s from colorectal cancer. But know that colorectal cancer, know that COVID-19 and the burden, the disproportionate burden is really a symptom of an underlying structural problem, okay? If we look further upstream, we start to see where some of these structural problems emerge. whether we're talking about income inequality, unsafe and overcrowded housing, lack of education, unemployment, poor access to high quality healthcare, those again help mediate part of what's happening downstream. If we're talking about COVID-19, we're talking about colorectal cancer or other chronic diseases. But certainly what leads to those midstream determinants, and what you've heard from Rhea and Marcella, is that we have to think about the direct impacts of racism. Certainly racism, poverty, and discrimination, those are what lead to the downstream, what we see symptoms of colorectal cancer, particularly disproportionately burdening African Americans. And as we think about this, what this describes, and both Rhea and Marcella touched on this, are social determinants of health, the conditions in which we live, breathe, work, play, pray, and age, and the larger social structures that inform those things and the power inequities in those. Okay, so let me bring this closer to the NCCRT conference. And let's consider a patient. Let's consider this young man, 55-year-old African-American male, single, widowed, with a young child, a low-wage employee who is insured. And certainly, you know, what we're talking about during this entire conference are ways to improve colorectal cancer screening rates, thinking about ways that obviously we impact the community, the patient, but also the providers, the payers, the employers. So let's consider this gentleman, 55 years old, African-American, has not been previously screened, so he's not up to date quite yet. And we want to get him to the point of screening completion. And so as we consider this process, and I'll submit to you that as I point out some of the barriers here that may prevent this gentleman from being screened, I want you to also think about the opportunities, particularly as Marcella and Rhea both pointed out opportunities. I want you to think about these opportunities they highlighted in the context of this patient. So certainly awareness. So, you know, did this gentleman, this 55-year-old male who is a low-wage employee working multiple jobs, did he have awareness in his community? Did he have awareness in his family about colorectal cancer screening, when to start it, why it's important? Was it a priority? So as you think about people's competing priorities, sometimes healthcare, preventive care services is not at the top of their priority list. So was this a priority for him? And if not, why might this not have been a priority, considering what Rhea and Marcella mentioned? Does he have a doctor? And does he have a doctor that not only he can trust, but that trusts him, as Rhea has pointed out, to make the right decision as far as screening? And that's part of what shared decision-making is. But so we connected this gentleman. So this gentleman was ultimately connected to a primary care physician and opted, after being given choices, to do a stool-based test. And so certainly his continuum of screening is not complete until unfortunately, his was positive until he completes his colonoscopy. And so what new barriers are now introduced? Now that he has had his stool-based test, a stool-based test that was positive, what are some other things that, as we think about how we mitigate, reduce, eliminate the impacts of racism on people such as this gentleman, this 55-year-old African-American male, that we need to overcome? Well, certainly, you know, part of one of the main reasons that people get screened for colorectal cancer is that they had a provider who recommended it. And that's the number one predictor that someone will be screened. Well, unfortunately, there are many who are not screened without getting a recommendation from the primary care provider. And certainly there is still some confusion around guidelines amongst some primary care providers in our networks, when to start, and understandably so, because guidelines have been changing. Certainly USPSTF just put out a draft recommendation about starting at 45, but before then it was 50, as compared to 45 for the American Cancer Society, as compared to the American College of Gastroenterology that had recommended screening African Americans at 45 starting back in 2008. And the United States Multi-Society Task Force in 2017. So we're given mixed messages, and perhaps that's part of the challenge. But also it requires that the patient be contacted. So he had a positive stool test. You know, is there an opportunity there or a challenge that he might have met by not getting a phone call to inform him, or not getting a message to his email? Or perhaps he's subject to the digital divide and does not have access to internet or Wi-Fi. What part could that have played in him potentially not successfully completing colorectal cancer screening? But also it requires a referral, right? So there has to be, and certainly there's been work that has been done that has demonstrated bias directly impacting the care that patients receive, and referrals being part of that. Even a patient who might have a positive stool-based test, perhaps this patient will not get referred to get a colonoscopy. And certainly we have to think about transportation. You know, one of the challenges that patients face, whether they're going straight for colonoscopy for their screening test or going as a diagnostic or screening completion, a test to colonoscopy after having a positive stool-based test, they have to have a ride to get to their colonoscopy. They have to have someone to bring them in and take them home. And that presents a challenge for some of our patients because some do not have access to transportation. Some do not have social networks that you might think come easy. Perhaps they're not connected with friends or family for multiple reasons. Perhaps they don't have a social network such as someone that may be at a church or a social group that can bring them. Perhaps they can't get the time off of work. Perhaps they don't have a car. Perhaps there are no reliable modes of transportation that they can take with someone to accompany them. And these are all things that we have to think about, particularly as we tie them back to social determinants of health, and yes, back to racism and implications for this patient's care. So I implore you, as you think about these barriers, as you think about the discussions we've had throughout NCCRT 2020, and you continue to hear the rest of the conference, I want you to think about this, gentlemen. I want you to think about opportunities that you have in your practice, in your health system, in your organization, your company, your research, to try to help navigate beyond these barriers, to try to mitigate some of the even social determinants of health. Why? Because this is our lane. Particularly, we can't be restricted to just wearing our white coats in clinic or just to our research labs or our offices. As we think about kind of what's happening peripherally to what we're doing in our work. But the solutions come when we get most proximal to those who are facing the inequities. And proximity requires that we take this into account, that we engage with our communities, engage with folks such as this gentleman in trying to navigate beyond the barriers that he might experience. And so as we think about best practices about how we do that, yes, best practices require community engagement and requires that we engage our members of our communities who have been disproportionately impacted by racism, disproportionately impacted by these social determinants of health, and particularly inequities in colorectal cancer screening, diagnosis, treatment, and survivorship. And we bring them to the table as we try to come up with solutions about how to mitigate them. Gone are the days when we can do helicopter research, right? And take our ideas into the community and hope they work. No, we have to have them at our tables when we do research and have them to actually contribute to the design of the study, the carrying out of the project, the discussion with the pharmaceutical company, right? This is how we are going to mitigate these barriers. This is how we are going to reduce some of this. But I must admit, we have to also do what Marcella was talking about. We have to think about those who are going into the community, who are having the conversations at the bedside, who are at the lab. We have to think about the scientists, the physicians, the clinicians, the nurses, the technicians, and do they look like the face of America? Do they look like this gentleman when this person comes in? Will they be part of the 2%, or are we going to raise that percent over time? There's work to be done, but I strongly believe that we can do it and do it together. Thank you. Steve, I'll pass it back to you.
Thank you so much, everyone, for a very enlightening half hour or so. So we would like to now open it up to the audience for questions. There's a few that have come into the chat room. I think the first one was from David Greenwald asking for the panelists if they can touch on the outcome of the recent election and how you, the panelists, think it might affect the healthcare outcomes in the coming years. I'm not sure if that refers to general healthcare outcomes like what Rhea was referring to, or colon cancer specific outcomes? Any thoughts about the future of healthcare and specifically colon cancer screening under the new world order, shall we say?
Can I ask a courtesy to allow Marcella to speak? I know that she has to leave. She has a pressing engagement, so I wanted to at least give her the courtesy of answering your question.
Thank you so much, Dr. Gray. Yes, I neglected to share that. I do have a few minutes, but I apologize for leaving early. Certainly, so here's the point where I make a disclosure that I am working with the Biden-Harris transition team and co-chairing an advisory board. And so most certainly, I will take the question from that perspective. You know, I think it's really important for this audience to know that the president-elect has long been very committed to issues of equity, and it's no different now. The campaign now, the transition is centering on equity and not in name only. This is about policies, right? If you're listening to the conversation today, it's where do we go in policies? How do we think about reimbursement? How do we consider what falls under the scope of kind of healthcare? We've all sort of touched upon how intricately connected access to resource and opportunity is, and that denial of it has really, that's what's driven health disparities. And so the transition team, the advisory board, and certainly the president and vice president-elect are knowledgeable of that and see that the solutions have to be multi-pronged. It's not just a healthcare solution.
Add to that if I can. First, I just want to say how excited and proud we were to see you working with the transition team, Marcella. I think I can speak for many of us and say it gave us a lot of joy to see your face there and to know that you're guiding future policy around the COVID transition. I'll also say I've heard a lot of people, and maybe this is just in social media, maybe in real life people don't say this, but on social media, a number of people were saying that they're really upset about how close the margins were. And I just want to touch on that a bit, because I think that type of a perspective kind of privileges the experience of white voters over other racial and ethnic groups in a way that we sometimes also mirror in healthcare, right? Like if you're going to say the margins are close, you must be only talking about the margins for certain white subpopulations. Because if you're talking about the margins for Black folks across this nation, but particularly in states that became critical as we were waiting for the return of states like Pennsylvania and Georgia, states like Arizona, we then were beholden to what the margins were for Black voters and Indigenous voters and Latinx voters. And when you looked at those margins, they were not close. And when they're not close, when 97% of Indigenous voters in Arizona vote Biden-Harris and 90% of Black voters across the US vote Biden-Harris, you know, and I think the data from LA Times said like 60 to 70% of Latinx voters across the United States voted Biden-Harris. That then becomes a referendum on the pandemic, on how this current administration has dealt with the pandemic and its disproportionate tolls on Black and brown folks. It becomes a referendum on the economy and how it disproportionately leaves or renders Black folks, Indigenous folks, Latinx folks vulnerable to unemployment and underemployment. And when we see that referendum, we have to call out that communities of color have a structural analysis of the failings of this current administration and the ways that white supremacy harms all of us in this country. And that's an analysis that we all need to hold. And it's one that I think in my entrance comments, I tried to carry forth, that there is an analysis in healthcare from communities of color about how healthcare, the systems have harmed folks. And we have to honor that analysis instead of just saying, oh, people don't trust the healthcare system. It's not just that people don't trust it, it's that people hold a largely correct analysis that our healthcare system perpetuates harms from racism and white supremacy. And that until we deal with that, we won't deal with racial health inequities in the, I guess, best way that we could.
I love that, and I'm not going to belabor that point. I love the points that you two made. You know, one of the things that I was struck by, as you know, on that Tuesday, and as I was looking at, you know, watching different clips from different news outlets, what was happening, was it was interesting for me to look at public record. It's public, you know, voter registrations can be public, but to look at some leaders of our healthcare systems and see how they vote. You get a lot of insight from that. A lot of insight, and that's quite telling, right? These are public records, and you can see, you know, how some folks are voting, and that's quite telling. And I'll leave it at that.
If I may, I have a question for Daryl. So, as you know, as a gastroenterologist, the ACG guidelines going back, what is it, 15 years now, said that we should be screening African Americans at age 45, and it really wasn't happening. In part because, as you said, there's mixed messages and it wasn't, you know, maybe all the insurers weren't covering it. But now that it looks like everything's going to move towards age 45 for everybody, what is your take, or maybe others on the panel? Do you feel that that may dilute out the resources that we have for screening, finally, African Americans at 45, in that now there's going to be a huge influx of all other individuals in that age group? Any thoughts about how do we redouble our efforts now that the awareness is to scope everybody or screen everybody at 45? What impact will that have on the African American community?
Thank you for that question. And I'd also like to, again, just to speak to the great nature and diversity of this conference, point out, you know, Samir Gupta, his session on that touched on this, and he's written about this, commentaries and otherwise. But I'll just say, is there a potential for that? Yes, sure, there is potential. That's one of the potential unintended consequences of this. But I think, you know, as we think about colorectal cancer screening and offering choice, you know, we also have to think about what we can do as a community of providers in making sure that we are participating in shared decision-making. Even as gastroenterologists who have traditionally recommended more colonoscopies and other forms of colorectal cancer screening, I think we have to revisit that dogma and really make sure that we are advocating for other screening tests as well, such as stool-based testing. But I think that it's also incumbent upon the makers of stool-based tests, for the companies, the organizations, the healthcare systems, to ensure that we are targeting African Americans, understanding the data that we discussed, the data that's been presented throughout this conference around African Americans. So there needs to be a targeted investment. There needs to be resources. So we can talk about this all day, but until there are resources that are dedicated towards changing these data, because there's people behind the figures. And so we have to always keep that in mind and keep that in front of our eyes, that there are people behind these statistics, and we have to put money behind it.
Great. Another question from Ron Du, if I'm pronouncing your name right, relates to wealth disparities. And you alluded to that, Daryl, in your slide about poverty and racism. And he's saying that health disparities are inevitably tied to wealth disparities, and our horrific inequities begin with the built environment of poor communities and extend throughout healthcare and legal systems. So maybe a question to either Rhea or Daryl: how do we adequately solve the root causes of systemic racism, and how is that really tied to poverty?
Rhea, I'm definitely going to pitch to you, because you are a scholar in this area. And again, I'm just humbled to be on a panel with you. But I'll just say this: sometimes our commentary around this is, some people try to minimize the impact of racism in trying to say that wealth or the wealth gap is the primary driver. And there are so many examples. I'll give an example about a colleague, someone, you know, I looked up to. I didn't know him personally, but who was quite wealthy. We think about people like Bernard Tyson, who was the CEO of Kaiser Permanente. He was not protected from racism. He was wealthy. He was not protected from racism. And we have to think about the harms, as Dr. Boyd mentioned, Rhea Boyd mentioned. Think about the figure that I presented about what happens, kind of the midstream and downstream impacts of racism. And certainly, yes, the wealth gap does contribute to inequities. There is no doubt. I am not suggesting otherwise. But I would submit to you that it's not necessarily, I wouldn't categorize it as the same impact as racism. Rhea, any thoughts on that?
Yes, I think you're saying this so beautifully. So I think there's a tension in medicine with whether or not racism can kind of be reduced to the effects of poverty on communities of color, like whether the health outcomes that come from racism are really just capturing the health outcomes that come from poverty. And I think you're capturing this really well, Daryl, which is that the answer is not completely. So even when you try to control for a racial group's socioeconomic status, you will still see a pervasive gap. There will still persist gaps in healthcare outcomes, even if you try to even out folks' socioeconomic status. What that tells us is that racism also harms health independent of an individual's socioeconomic status. And I'm glad you brought up, Dr. Tyson. I think there is also data to tell us that as particularly African Americans progress in education, the mortality gaps or the life expectancy gaps between Black and white populations actually widens the more education you have, the more wealth you have, which some people have suggested speaks to the additional forms of discrimination and racism that Black folks are subject to as you try to move up in class in this country and as you go through higher education. So I think, yes, we do want to narrow the wealth gap because it is also a manifestation of racism, but we also have to own the ways that racism operates to harm health independent of the wealth gap. So I'll give one last example and give everybody a term. One term for how we can address kind of health inequities is targeted universalism. It's that you can have programs that target everybody, just like you were saying, Dr. Itzkowitz, with what if we move colorectal screening for everybody to 45? Yes, that will help everybody, and it will help some Black folks, some that you moved it earlier, but it still won't respond to the gap. It still won't narrow the gap. And so like Daryl was saying, you still need a targeted intervention. So when it comes to wealth inequality, some people say that we could have something like raising the minimum wage that would improve poverty for everybody. Am I a proponent of raising the minimum wage? Absolutely. Will it help Black folks? Yes. But will it narrow the fact that, and this is a quote from the Roosevelt Institute, that $1 of income and wealth actually buys less health, it buys less safety, it buys less wealth for Black folks than white folks in this country. So we really do have to confront the ways that racism shapes outcomes independent of somebody's economic status.
Your comments really resonate with me because I just finished reading Isabel Wilkerson's book about caste. And it really raises the issue of caste versus racism. We only have a couple of minutes left, and I'd like to just ask one last question. How do we hold institutions accountable and encourage them to take substantive action instead of releasing statements that are mostly performative activism? A lot of faculty doing this important work do so with no or only nominal institution support. And I guess it gets to your point, Rhea, that if you're not an active anti-racist, you're just perpetuating racism. Any thoughts about how we get our institutions to be more active as anti-racist institutions?
Steve, thank you for that question. And I think you are a good example of this. So number one, I am appreciative of you leading this panel. And it speaks a lot because it speaks to a couple of things. And it speaks to the NCCRT in a couple of things. Number one, it probably would have been easy for the NCCRT to have, a Black male or a Black female leading this discussion. But I think what's important that the NCCR did was they had a white male. So the dominant person represented in healthcare and science to talk about this topic. And that's what's important too. So as we think about institutional commitment, it can't be Rhea and I as the only people for our institutions out here talking about it and preaching it. It has to be the Steve Itzkowitzes. It has to be the CEOs. It has to be the chancellors. And they have to be forthright, not just in the statements, right? It's easy to write a statement, but it's a little bit more difficult to meet with people and to talk with your employees about your commitment and to what money you are putting towards this commitment. And as we think about the Rheas and the Daryls and the other academicians, people of color who are doing this work and often asked to lead diversity, equity, and inclusion initiatives without advancing, promotion, advancing pay, tenure, the resources to do the work. That's the opportunity. That's where the opportunity lies, is to put the resources there. Think about the research, the faculty and staff who are doing the work, and we have to put money behind all those things and evaluating our practices, whether it be hiring or otherwise, that inhibit that.
Rhea, we have 30 seconds left. Any parting comments?
I mean, yes, Dr. Gray's preaching today. First, I just want to say amen to all of that. And just to underscore the point that I put in the slide that we will share with everybody, which is essentially that if we're going to respond at scale, right, at a population level to racism as the public health crisis that it is, we have to name it. So that is a step. But naming it is only the first step and is completely insufficient. After you name racism, you have to identify the mechanism by which it's working. For institutions, that means institutions have to own specific and articulate specific ways that they have either benefited from racism, exacerbated racism, or ignored racism within their system, which allows it to persist. And then once you identify those specific ways, then you have to work to eliminate it. And that's something that we should hold all of our institutions' leaders accountable to.
Thank you so much. I think this has been a wonderful session. There was a lot of comments and compliments in the chat box. And Erica Breslau from the NIH would like us, all the speakers, to come up with a reading list, perhaps your own papers. And if you Google our three panelists, you will have such a rich reading list. It'll keep you busy for probably about a month. So we'll try to work with the roundtable staff to see if we can distribute a reading list for this session. So I want to thank everyone. We will take a 5-minute break now and reconvene at 3:45. Thank you all.
Thanks for having me.